Okay, so for our last formal talk today, we have co-chair Dr. Bedimo, who's going to talk about FOMO, which is fear of missing out, FOMO no mo. So what that means is that this is kind of what we couldn't cover in lectures in the time we had, but stuff that's new put into one talk. So his challenge is to do the FOMO talk without MEOG, which you know what that means? My eyes glazed over, or MIGO. So let's see if he can do that.
Thank you so much. I think when I get back to Dallas, I'm going to start a petition for the mayor to put pitavastatin in drinking water. And so here are the things that I hope have come in the past year or so that might be relevant to your patients. And these are my disclosures. And I group them here into what is important to review in our progress towards the ending the HIV epidemic. Like Dr. Chiva has said, one of the pillars is PrEP. And how are we faring with PrEP, and what are the effects or concerns about PrEP? Management of treatment-naive or treatment-experienced patients, that will be covered amply, but I will just mention something about the two-drug therapy and what we could improve on that. And then the prevention and management of opportunistic infections, a couple of things. One, the prevention, we mentioned, we heard earlier about syphilis and its rise, unfortunately, but let's also talk about HPV and the treatment of TB meningitis. Then non-AIDS complications of HIV disease, cancer in people with and without HIV, that incidence is not so straightforward. And then we look at the mechanism of cardiometabolic risk in people with HIV. Weight gain, as has been talked earlier about, and the GLP-1 agonists, and in the general population in people with HIV. We'll close on with COVID-19, newer findings about post-acute sequelae and efficacy of vaccines in immunocompromised patients. This is such a potpourri, and we'll cover it hopefully in the allotted time. Oops, sorry. And now, first in the progress towards ending the HIV epidemic, what are the regional differences, and what are the PrEP guidances, and what are the metabolic effects of PrEP? This is unfortunately what was the result of the COVID pandemic, that there was some undercounting and sometimes probably also under prevention of HIV. And on the right, you see that the bulk of the disease is still in the South. That has not changed much. And what is new is the new U.S. Preventive Service Task Force guidelines on PrEP. Essentially, what the key word for these guidelines is everyone. Looking for risk assessment in detecting who should be on PrEP is inadequate. There is no adequate tools. Using cutoffs for PrEP consideration is silly because HIV diagnosis is frequently missed or delayed in older people, and that delay is more costly than in younger people because the disease tends to progress faster and with a steeper decline in CD4 cells. Do not forget the populations that bear the bulk of the disease, gay, bisexual, other men who have sex with men, because they accounted for 71% in 2021. And then reassess the barriers to PrEP. The so-called PrEP to need ratio is abysmally low. The people who could benefit from PrEP over the people who actually use PrEP over the people who could benefit from PrEP is low. And that PrEP to need ratio remains low because of us. We are the main barrier to PrEP use because we're not familiar with PrEP, we're not comfortable with PrEP, and because we perceive that the risks are high for one reason or another. So let's look at digging up the old data on PrEP safety from the IPREX, where TDF FTC was compared to placebo in cisgender men and transgender women in 6 countries. You can see on the right that yes, TDF was associated with a small but statistically significant decrease in bone mineral density over 24 weeks. And that decrease started earlier and then stabilized thereafter. Short-term decrease over 26 weeks, stabilization thereafter, exactly mirroring what happens when you use a TDF-containing regimen in people with HIV. So that's important to bear in mind, and these are younger people than usually those with HIV. A newer analysis of this data on TDF, my name is falling, and TDF FTC shows you that on the left, you do have focus on the green line. The green line is people who actually adhere to PrEP because they have detectable TDF levels. And you will see that there is no significant change in lean mass, but there is a change in total fat mass with TDF. So you've heard a lot about the weight suppressing effect of TDF. It is important to look at what weight, lean or fat, and this is an inkling. But now we have three options for PrEP. We have TDF-FTC, we have TAF-FTC, and we have cabotegravir. So it's important now to begin to customize or think about individualizing PrEP use. This is an analysis by Caso Permanente. There are two cohorts without baseline hypertension or statin use. Some used TDF, FTC PrEP, which is, and others use TAF-FTC, and they did propensity score matching. And what they found here is that the incident hypertension on this slide or incident statin utilization on this slide were higher with TAF-FTC PrEP compared to TDF-FTC PrEP. Now, this is data that will need to be looked at and confirmed in other cohort and hopefully on trial. Now, this is in contradiction to what the Discover trial did show when they used the TAF-FTC compared to TDF-FTC. So that is just something that we need to look at, and why was the difference? Now, for the management of treatment-naive and treatment-experienced patients, there is what I will call a call for emission creep for two-drug regimen options. Now, I will explain. So what are the options for two-drug therapy in people with HIV who are already virologically suppressed? Now, there are two drug options for treatment-naive, and there are two drug options for virologically suppressed patients. And you can see a number of options with a number of classes substantiated by a number of studies. Then let's focus on the last one, cabotegravir, rilpivirine, Atlas, FREYR, Atlas 2M. After that, you got SOLAR. Now, we do have to remind people that when you use these options, you do not usually have two drugs that are active against hepatitis B. So caution for people who are HIV hepatitis B co-infected. Now, with cabotegravir, rilpivirine, what a lot of people have been saying is that there is one large group of left behind, which are people who, because we're asking them as a currency to obtain this option to show us an undetectable viremia. Now, the left behind is people who cannot show that card of undetectable viremia for whatever reason. So it's important to look at that. This potential additional indication could be just those people. Now, what is the price? What is there to lose to use it? And then the Ward 86 starting in San Francisco by Monica Gandhi to the OPERA cohort, and then in Australia, the jabs, I will present all those briefly, suggest that especially in people with high social determinants of health who have some significant challenges in remaining on oral therapy and being undetectable on that, this could be a life-saving option. So I am not telling you to go outside of the guidelines, okay? I know that HIV providers are always mavericks. They don't wait for guidelines. but, but please don't. And then then another option is, temporary inability to take oral medications. I had a patient last week in the ICU that I thought, boy, it would be just easier. Rather than coming up with what is crushable and put in NG and other things, to give that person injectables, and then we don't have to worry about this for another month or two. So this is my call for mission creep. And I'll start with the Word 86 by Monica Gandhi, long-acting cabotegravir ripivirine implemented using rigorous protocol, including a biweekly patient review. Now, don't try this at home because the wraparound services need to be significant to be able to use this. And then the inclusion criteria, virologic suppression was not required. And then they had to agree to come to clinic every 4 weeks, provide contact information, and then there was an outreach. Now, the bottom line is that not only did the 76 patients who were already suppressed remain suppressed, 55 of the 57 who were not did suppress. These are 55 patients that they would not have suppressed otherwise. So that's another way to look at this. And the OPERA cohort did its own analysis, including those receiving first-time long-acting cabotegravir ripivirine between 2021 and February 2022, and then the follow-up by March 15, 2022. That's 383 patients. Now, they had a small number who were viremic, over 200, and then 91% of those achieved viral suppression. That's another argument. For the Australians, they use what they call complex medical needs, social vulnerability, and historical non-adherence. Now, difficult to treat patients. Okay. And then they found that they had, similar adherence and efficacy rates than was seen in phase 3 trials. So consider this. So there have been considerations in the guidelines bodies. Let's see what the future holds. But now prevention and management of opportunistic infections, unfortunately, and this is not something that we did not think we'll be talking about in 2023, there is a dramatic rise in syphilis in the US. With that rise in syphilis, there is a rise in congenital syphilis. And so we had 231 stillbirth and 51 infant death. And two of the most important determinants of congenital syphilis, a lack of timely testing and adequate treatment, that contributed to 9 out of 10 cases. Now, Dr. Meredith Clemens will talk a lot more about syphilis. So this all I'm going to tell you is that coupled with the fact that somehow penicillin disappeared, I have no idea. So I'm hoarding it. So we need to comfort. So we've heard a lot about herd immunity during COVID, and some of us don't even want to hear about that term anymore. And this is an important consideration of herd immunity with HPV vaccination. In this particular study in Europe, so they had 3 groups of communities that had 3 strategies of HPV vaccinations. The first group, they had a gender-neutral vaccination. Boys and girls were vaccinated. In the second group, in the middle, only girls. And in the third group, there was no HPV vaccination. And then they went and looked back 4 years later, and then again 8 years later. The results were dramatic in that there was a community-level depletion of the vaccine-targeted HPVs, the HPVs related to badness, 16, 18, 31, 45. And that was significant, but that is not all. In the gender neutral, when you give vaccines to men and women equally, boys and girls, you only needed to achieve 50% coverage to nearly eliminate occurrence of high oncogenic HPV in the population. You will need more than 90% rate of immunization of girls only to achieve the same. So this is shocking, and I'm not sure it made as much news on this side of the Atlantic as it should have, because it has the potential of altering our guidelines, and I hope that we look at this type of stuff. Now, this just to for those who want numbers, and you can look at them later about how much this worked, but we've covered the gist. So now, in terms of opportunistic infections around the world, TB still looms large. And it's still, TB meningitis is still an issue in the US, but much so outside of the US. And it's associated with a significant mortality, over 50%, despite therapy. So looking for a better way of managing TB, if you've been following, another opportunistic infection that has a lot of mortality in people with HIV in the global south is cryptomeningitis. And there have been a lot of studies looking at how much liposomal hepatitis B and other things. So in TB, one all people know how to do is give TB medicine and maybe give steroids. The steroid part had absolutely no evidence. So now this is the evidence. Adjunctive glucocorticoid, widely used, lack of evidence, but had no difference in mortality. And, but thankfully, at least in this study, as it's suppressing the sometimes very poor immune function to begin with, it was not associated with an increase there was no significant decrease in iris. Now, when you think about neurologic OIs, you always say, okay, let's worry about those who start ART, and if they have to start, let's start steroids. But there was no importance in this particular study for steroids in TB. That's important. Now, let's move on to non-AIDS complications. Those were the AIDS-related complications. And I heard Dr. Rinsmo talk about the men and women when it comes to statin efficacy and cardiovascular event. And let's look at non-AIDS complications. So these are non-AIDS cancer and AIDS cancer incidences. And look at these three curves. On the left, you have everyone. In the middle, female. On the right, male. First, as you age, you're more likely to die. Shocking. That's the blue. So, and then let's focus now on the non-AIDS cancers in green. In people with HIV, so green dashed line, and those without HIV, green solid line. And those without HIV, green solid line, it's really an increasing risk of these cancers as time goes on. But what's remarkable is in the green dashed line, non-AIDS cancer in people with HIV, it really, in people with HIV, you get this solid line, and those without HIV is a dashed line. What you see here is that if you look at people with and without HIV after age 65, those curves are now the same, the rates are the same. So this is a very interesting implication. We don't know the future trajectory of these curves, but we have to realize that the incidence of these malignancies, if you compare people with HIV and those without, largely depends on when you looked. If you work like me at the VA when everybody is here, we've seen very interesting nuances. And if you drill down further in site-specific non-AIDS defining cancers, the picture is even more interesting. For instance, let's just focus on what's in the box here. There is a lower incidence of breast cancer and prostate cancer in people with HIV when they're over age 46 for female and 50 for male. So this is really interesting in that when you start reading data or start looking, advising your patient whether the PSA measurement is significantly important or more important than others, it depends on when you're seeing them and how old they are. And then maybe one day somebody will do mechanistic studies to see, is it just the fact that inflammation, hand waving, Jason, inflammation, and is the driver, and that is no longer as significant compared to other drivers like older age, but it's very interesting to look at what these nuanced pictures tell us. Now let's go back to metabolic complications of antiretrovirals. in the past 5 to 6 years, weight gain has been what has bothered people the most, and with instis and TAF, there has been data looking at dolutegravir and adipocyte toxicity, and this is newer data that suggests that bictegravir alters glucose tolerance in mice and glucose metabolism in human hepatocytes. So they just might be, now don't put 2 and 2 together yet, but we know that this is an enteroviral that is somewhat associated with increased age, but increased weight, and also we need to understand other metabolic complications that may come along with it. They could be unrelated to weight or not. Semaglutide, and Dr. Greenspoon mentioned this a little bit, did not achieve as greater a decline in cardiovascular outcomes in people who are obese but do not have diabetes, at 20% compared to 35% for pitavastatin. But that was huge. That was deemed to be big enough that it made news. Now, so we're now struggling with people with HIV who gain weight. And one study, and I think I applaud this one because it's one of the few studies that begin to tell us what part of weight. And so you look on the left here, you see that in what Grace McComsey did in Case Western, looking at people on placebo compared to semaglutide, weight decreased 65% on semaglutide and 4% on placebo, lost over 5% of the weight. That's the good news. The cautious news is that the total lean mass decreased more on semaglutide than in placebo. And it more so subacute subcutaneous adipose tissue and lymph fat also decreased. These are not the things that we want to drop in people with HIV. Somebody mentioned earlier, asked a question about HIV-associated weight gain. We don't have that dealt with already, so I'm not so sure that we should overlook this potential effect, so much left to study. Let's conclude with COVID, and I think that we have vaccine response in people who are immunocompromised, and I think that this is brand new, very simple. If you see someone now who's unvaccinated, just give them either 1 dose of the mRNA, Moderna or Pfizer BioNTech, or 2 doses of Novavax. If that person is immunocompromised, it moves to 3 doses. It's great to see guidelines that are based on data, and this is the data. The antibody response, it was already shown last year after a 3rd dose of mRNA vaccine in hematopoietic stem cell transplant recipient significantly increased. The problem is that these results were not compared to those of healthy controls. Until now, in this Japanese study, compared to healthy controls, those 3 doses of mRNA were actually led to antibody response, getting to what that 1 dose of mRNA did to the people who are not immunocompromised. The immunocompromised have been left behind of COVID. They cannot relax their guard. They cannot lower the guard if they don't respond as well as the vaccines as others. So finally, post-acute sequelae. Most of COVID management is predicated upon the fact that let's look at how it reduces risk of getting hospitalized or dying in 30 days. Now, everything doesn't stop after 30 days. It was good that the CDC thinks that the post-acute sequelae burden may have decreased, but still a substantial quarter of the people may have experienced or may be experiencing it. So good news is emerging that antivirals during the acute phase might prevent or decrease the risk of these complications of post-acute. This is for nirmatrelvir, ritonavir, and then there has been data presented at CROI, and I'm still waiting to see if this is going to be in print, for in situ review, which is not commercialized here yet, but in Japan, that did significantly decrease the risk. That's because it was a trial and it was a pre-specified endpoint. The onset of post-acute sequelae of COVID. And then finally, to toot our own horn at the VA, we have the analysis of the VA, I was not involved, looked at absolute reduction of post-acute sequelae. Now, why is all this important? If you have someone today, and I'm sure you do, who think they may have COVID, A, they're less likely to get tested because they think it doesn't really matter. And two, even if they test positive, they don't want to take medications if they don't think they have risk factors for disease progression or death. If it's possible that you may also be preventing these long-term complications, that just might be relevant. And then I will conclude briefly with this story about virologic rebound. Initially, in the trial of nirmatrelvir/ritonavir called EPIC-HR in high-risk people, there was no difference in virologic rebound in people who did or did not receive nirmatrelvir/ritonavir. However, this is what came out last month. Big head scratcher, much higher risk of virologic rebound with nirmatrelvir/ritonavir versus no treatment in this cohort in Massachusetts. Now, there is a lot of caveats in looking at rebound, virologic rebound. How often did you check the viral load and until what date? So it's hard to compare studies. Also, this one is because we do not have a good way of saying that people who did not receive nirmatrelvir were the same as those who did, because of course, if you're more immunosuppressed, you're probably more likely to receive the drug. So thank you, and hope to get some time for questions and answers.
Well done. That's a lot of stuff. So everything is fair game, and then even some stuff that he didn't present, if you know of some data that you'd like to talk about. You know, this business, to me, the benefit of Paxlovid, if you will, is really best when used in the first 2 days. And if you're playing a relative risk game of some virologic rebound, to me it seems worth it. What do you think?
Yeah, what is unfortunate and confusing is that in this analysis, I believe it was in Mass General, rebound was more likely if you started treating earlier in the first 2 days. Now, go figure that one out. So it's just that probably the COVID, you know, you're not allowing the immune response to COVID to mature. I don't know, but it's still very confusing.
Okay. Here.
Hi, thank you for this update. I'm curious about the evidence on non-AIDS cancers, and my first thought was people living with HIV are hopefully more engaged in care and possibly receiving more sort of routine health maintenance. I was just curious if there was any differentiation in the people living with HIV in the type of care they were receiving. Like, were they being seen in Ryan White-based programs, or were they being seen by specialists? Probably more detail than is available, but just curious.
Yeah, those who were seen in Ryan White Clinic had no AIDS. No, just kidding. It's always a consideration because thankfully people who are in care with HIV are seen more often. So if there is any screening, it's relatively related to how often someone gets seen. But those were controlled for, and it still would not account for this skewed aging incidence. So.
About HPV and the commentary about sexual activity over the age of 45. This was written by a 46-year-old. And that is continuing. Why not use does the HPV risk just sort of disappear as you get older? Should they be vaccinated as well, in other words?
Yeah, I mean, the simple thing is that it's not worth waiting until you get HPV. So that's why we want you to get vaccinated early. And the Norwegian study is just striking because if you did that gender neutral approach, you don't really need to have that much uptake in vaccination until you replace, because there was, what happens here is replacement of the types from the bad ones, the oncogenic ones, 16, 18, 31, 45, to the non-oncogenic one, and everybody wins because what you're more likely to get, whether you had sex at 47, it's the non-oncogenic ones.
Okay.
Could you please clarify the vaccination doses for COVID? I'm over here.
Okay.
So wait, he's in this time zone.
For COVID, and you say whether they're immunocompromised or not, and then what surrogates are you using? A CD4 count if somebody comes in acutely with AIDS, and
Yeah.
how long do we wait to vaccinate them with the newer vaccines, please?
Yeah, so let's break that question in two. Number one is who is immunocompromised? We struggled with that because the ACIP, ever since 2020, we don't think that they've been granular enough in defining who is immunocompromised when it's HIV. They say advanced or untreated, actually, those were the words. And which, that doesn't mean anything. So everyone was left to translate that. Is that CD4 less than 200 or viremic, not on treatment? So that's the first end. But the other ones are very spelled out, the hematopoietic stem cell transplant and so on and so forth. So those are the who. The guidelines has on immunization, of course, as you see, have changed a lot since the inception of these vaccines at the end of 2020. What happens now is that if you have had any, previous vaccine, what they want you to do is if you're immunocompetent, get 1 dose, immunocompromised 3. Now, what I would say is that I don't really want to take the ability of somebody to respond as a deterrent to not vaccinate them. I would vaccinate them, and I think that in people with HIV who have, if you look at the mortality with COVID, the data and progression that came out last year or so, it's the 200 and below that you have to worry.
Right, and that's kind of what this question was about. What is immunosuppression? I would just jump on the bandwagon here and say that we have this tendency to equate CD4 count with immune function, and that really isn't the case. It's natural how we got to that thought because early on, before we knew that there was a virus and that what the virus is, HIV, in the early 80s, the CD4 count was used as a relative epidemiologic marker of relative risk for pneumocystis and CMV, et cetera. But as we've had more experience and have drugs that can take the viral load down to undetectable levels, it's really the virus that's the immunosuppressive agent. It has really little to do with the CD4 count. And you know that because if you give somebody, or when you give antiretroviral therapy, especially somebody with an advanced infection with low CD4 counts, the viral load drops precipitously, and 3 to 4 or 5 weeks later, you can get IRIS. And it's not because the CD4 count has risen. In a lot of cases, it sort of remains flat. It's the virus that's dropped, and the virus now cleared allows the immune system to function better. So I would be very specific and say, in my opinion, that somebody with HIV is immunocompromised when their viral load is not only detectable but high, and I would say over 1,000. So somebody with the suppressed virus for a long period of time, even if their CD4 count hasn't risen above 100 or 120, I would not count them as immunocompromised.
No, I totally agree. Translation is the virus stupid.
Yeah, that's exactly right. So on that positive note, it's the virus stupid. we're going to conclude the afternoon session.